Motor Vehicle Crash Patient Assessment. Obviously, your first priority is your own safety, which includes a good hazard survey of any motor vehicle crash scene. Information about the mechanism of injury for your patient can include the impact area on the vehicle relative to where the patient is seated, the impact speed, any passenger compartment invasion that occurred, is there any steering wheel or windshield damage, and were seat belts or airbags in place. The first 30 seconds of your survey is all based on finding immediate life threats. Your initial assessment will include a look at level of consciousness, airway, breathing, and circulation, although you don't have to do them in that particular order. A lot of this is done concurrently. Any patient who is not alert certainly can have airway management concerns. Is the patient able to manage their own airway, or are they not fully alert? Is there blood or other foreign bodies in their airway? Assess the patient's breathing, their rate, too fast or too slow. Are they using extra effort to inhale or exhale? And are they breathing deeply enough? And finally, a check of circulation is important. One of the easiest ways is to assess for radial pulse. The presence of a radial pulse gives you an idea that there's an adequate blood pressure. The absence of radial pulse then obviously means there's not an adequate blood pressure. Also check for the pulse rate. If you remember that shock is assessed based on tachycardia, and so a tachycardic patient may give you an indication that they are showing signs of shock. Check quickly for their skin, color, temperature, and moisture, again an indication of shock, and then look for and manage any major external bleeding. So at this point you've had about 30 seconds of contact with your patient. If you've found a problem to this point, the patient is automatically a load and go. You should call for a C-collar and backboard, begin to package the patient, and you will not have time to use a KED board for these critical patients. But if you did not find a problem in the initial assessment, that doesn't mean your patient is not a load and go. They could still have a significant injury to one of the critical areas: head, neck, chest, belly, pelvis, or femurs. Now's the time to check those. You have another 60 seconds to do what's called a rapid trauma exam. The rapid trauma exam should be done when you find problems in your initial assessment while you're gathering backboard and preparing for rapid transport, but also if you haven't found anything in your initial assessment. Now you got another 60 seconds to check those critical body areas. The idea here is to find all the life threats within the first minute and a half. The rapid trauma exam is not a detailed physical exam. It's a quick check, just a few seconds on each of those critical body areas. Spend just a few seconds checking the head for any major injuries. Assess the neck for any major injury. Look for jugular venous distension or JVD. Check the trachea for midline position. About half of your time spent on the rapid trauma exam will occur on the chest. You want to look, feel for certain, and if you can listen with a stethoscope at this point, that's important as well. So a stethoscope is helpful in your rapid trauma exam. Look and palpate the abdomen in all four quadrants. We're looking for tenderness and or rigidity. Assess the pelvis by pushing on the iliac crest and also doing a lateral squeeze or barrel hoop pressure. And then spend about 5 seconds checking each femur for swelling, deformity, and tenderness. If after this first 90 seconds you found nothing on your initial assessment or your rapid trauma exam, then you can conclude that this patient is not a load and go. Call for a collar and backboard, and these patients should get a KED for removal in most cases. We believe that the KED does provide better spine protection than other methods of removal. But we do know that KED application takes at least 5 or 6 minutes longer than other removal methods, and that's the best case scenario. So you have to determine if the speed with which you'll be able to remove your patient by not using a KED is really worth it to the patient, or will the patient actually be better protected overall with KED application and slower removal. In a first response situation, this may be a factor of how far away the transport vehicle is. If the transport vehicle is 5 or 6 minutes away, it would seem reasonable to place a KED on almost every patient. Your only two options are really to use a KED or to make a KED with your hands and your partner's hands. There has to be some stabilization of the spine for removal, whether or not you use the KED. So we have a list of 4 times when the use of the KED would not be appropriate. And obviously one is when your patient is unstable. You simply don't have time to place the KED. You will need to use your hands to simulate a KED in order to get the patient out much more rapidly because the patient is unstable and needs immediate care. In some cases, your patient is stable and would ordinarily get a KED, but that patient is blocking your access to an unstable patient, and so overall patient care is best if you do not use that KED on your stable patient in order to get them out of the way. In cases where the vehicle is on fire or there are other immediate rescue scenarios in place, an urgent move would be necessary, and it would take too long to apply the KED. So one of the 4 times not to use the KED is when your scene is unstable in terms of a rescue situation. Then the last of the 4 is when the KED is unstable. It's damaged in some way, or the patient is simply too large or far too small for the KED. So 4 times not to use it. Patient's unstable, they're blocking an unstable patient, the scene's unstable, or the KED is unstable. Some ambulance crews that you work with will direct you to not use the KED. There are a number of different opinions out there. Once that ALS crew has assumed responsibility for the patient, they make the call on KED use or not. However, we would point out that ALS crew must be physically present. Don't assume because a certain service is coming to you or you know a certain paramedic's coming to you and they, quote, never use the KED. Don't assume that. Once that crew member's in place physically and can make that call, then we'll follow their lead. If you're looking for more information on a hazard survey, there's an excellent video out there from Chief Ernie Rhodes on Wires, Tires, and Fires is the title of it. And then we'll provide you access to the KED Owner's Manual and another presentation that's dedicated to KED application.